Greetings, Paul Auerter here, site advisor for the Medscape homepage for infectious diseases and clinical director of the ID division at Johns Hopkins. Topic today I thought I'd spend a few minutes about regards prosthetic joint infections. These are a common source of consultation for infectious disease physicians and quite troublesome for patients and surgeons when they encounter these infections. Two papers of interest this year have grabbed my interest and maybe changed some of our clinical practices, so I thought I'd tell you about them and see how or if they should impact your own clinical practice. Most of this centers on Propionibacterium acne, a pathogen that we usually think of low virulence and present on the skin and traditionally perhaps part of the pathophysiology of acne. However, the two papers I wanted to call to your attention, one is from France, from Levy and colleagues, published in Clinical Infectious Diseases in June of 2008. In this study, the investigators looked at knee and shoulder prosthesis infections and then obtained samples for prolonged culture, specifically looking for P. acnes. Of the 16 shoulder infections, 9 of their patients had P. acne, whereas only 1 out of 233 knee infections displayed this particular bacteria. The investigators came to believe that P. acne was indeed playing a role in these shoulder prosthetic joint infections and wouldn't have really encountered them if the cultures were only held for the traditional 5 days, as these are rather slow-growing and somewhat fastidious organisms that require prolonged culture from 7 or 14 days. The group also treated these patients with oral amoxicillin and rifampin, and in 6 of the patients at least cited a favorable outcome in those patients treated. A newer paper was published this December by Schaefer and colleagues in the December issue of Clinical Infectious Diseases. And this group looked at only loosened knee and hip prostheses, 284 to be specific. And the point of this study was that they actually went out of their way to hold cultures for a full 14 days. Of that group of patients who were deemed as having infections, 27% of this cohort with infections were identified with infection only after 7 days of having the cultures held, up to a total of 14 days. And of that group, they found organisms such as P. acne, coagulase-negative staphylococci, Peptostreptococcus, and Propionibacterium. Although they didn't really wrestle with all the organisms there, specifically the Propionibacterium and Peptostreptococcus, the P. acne and coagulase-negative staphylococci specifically were deemed more likely significant and had growth up to day 13. So these authors really made a plea for extended cultures. Now, how is this relevant to all of our practice? I think at many institutions, cultures that are obtained by surgeons with suspected joint infections are typically held for 5 or so days. What we've done here at Hopkins, specifically with our shoulder infections, is to hold cultures for an extended period of time, that is 10 days, and we've been beginning to see more P. acne from these cultures. Now, the more recent Schaefer paper, and these references hopefully are cited next to this blog for you to investigate further, found significant pathogens such as P. acne in knee and shoulder, whereas the Levy paper did not. As with any research, I think this raises far more questions than really answers. We've begun to hold our cultures longer for shoulders. We're not sure we are going to do that for knees or hips yet. Obviously, holding cultures is significant demand on the microbiology laboratory. However, we're asking our surgeons to always try to obtain 3 or more samples of tissue and or fluids from suspected joint infections. And of course, if you have 2 specimens with the same pathogen, or 1 and tissue consistent with infection with lots of polys and so on, we tend to take that as significant. Whether aspiration of joints a week or two before planned surgery are useful, and whether these should be held for longer culture times is unclear. I would take this to mean that perhaps we should begin holding these cultures longer and beginning to incorporate this information, although quite honestly whether all organisms such as these of low virulence are involved in biofilm formation that's causing trouble or pathogenic is a very difficult one to answer. But I think when dealing with joint infections, there's probably a tendency to treat all comers to have the best outcomes when trying to replace or improve these situations of infected joints. So obviously more food for thought, but you may want to work with your microbiology lab. I think many surgeons are hearing about P. acne and other such low virulent pathogens, and extended cultures may be important to consider as we're beginning to better understand how to handle prosthetic problems when they no longer work well, whether they're due to infection or mechanical problems. Thanks very much for listening, and we'll see you soon again.